an introduction. So my name is Jessica Mock. I'm one of the consultant bariatric surgeons here at Homerton. And recently Mr. Sanjay Agrawal also passed on the lead role to me, which is an absolute honour. So a bit about me. The reason why I'm doing this topic is that my research interest is in suboptimal weight loss after bariatric surgery, and my PhD thesis, which has just been submitted, was on the role of GLP-1 on optimizing weight loss after bariatric surgery. And the aim of my talk is to, on a practical level, go through what you would do if one comes to you with weight regain. And I think the really important thing, first of all, is to avoid this. This is what I call the circle of blame. We've all seen it. The patient comes in, something is wrong with my operation, and surgeons think, well, you're clearly not following the dietitian's advice, or the dietitian haven't done enough. Dietitians say, well, those are behavioural issues, and it goes around, so it's unhelpful. So I have 3 take-home messages to start with for the patients when I start the consultation. The first one is that actually suboptimal weight loss and weight regain is really common. 25 to 30% of patients experience this. Unfortunately, in most of our education sessions, patients focus on the blue lines that are on the graphs here, which is the average weight loss. But for the individual who are on the lines further down, this is unhelpful, and they don't see that. It's really important to highlight, actually, there is a high variability in weight loss after bariatric surgery. And this one, actually, is something that should be on the education session before the operation, and it isn't, it really should be, is that the weight loss pattern is different for sleeve and bypass. I'm going to take you through some of the data I've gathered from my trial as well as from my PhD studies, which is a study that looked at patients with suboptimal weight loss. So the cohort of patients, the definition we used was less than 20% total body weight loss after a year of primary sleeve or bypass. This isn't going to be a surprise to anyone. The weight nadir happens earlier in the sleeve compared to the bypass, and it's also so the regain is earlier. So if we're looking at optimizing that weight loss and capturing and doing interventions, we're really thinking about doing that earlier with the sleeve hysterectomy. This is important. Actually, the degree of weight regain is different from the bypass in the sleeve. People who've had a real wide gastric bypass regain to a lesser degree. In this cohort, there was about 500 patients. Actually, you hardly see anyone who has full weight regain without bypass, and I'm sure all of you will agree that that is actually quite uncommon, and I think patients need to know that. Again, this is showing the variability for patients who've had the sleeve with weight regain is much higher compared to the bypass. None of the patients who had bypass actually regain higher than their original weight, whereas you could do that in the sleeve hysterectomy, and a good number of patients did that. This is again another important point number 3, is that there is gut hormone response change with bariatric surgery in terms of comparing the good versus optimal weight loss. So as you can see here, actually patients who've had good weight loss have a good GLP-1s and PYY response, whereas patients who have suboptimal weight loss tend to have a suboptimal response from the gut hormone response, which is what might be driving actually that suboptimal response. And this, I think, ultimately takes away that blame, is that it's a biological event. We all have different response to surgery from a biological perspective. So it's something that we would, in the interventions, work with rather than blaming, did something go wrong with the advice versus the surgery. Again, the GLP-1 response after wide gastric bypass and sleeve is also different, and I think that's an important point in terms of what you're going to try and achieve in terms of treatment for suboptimal weight loss after the bypass and sleeve. And I'm not going to go into details, as the following speakers I'm sure will go through those. So the next point is to look at, well, what are we going to do now? And it's looking at that contributing factors. Although genetics will have a huge amount of contributing factors, this isn't something we can do much about. But there are lots of other things that we could potentially work on, and I've kind of divided those into patient-related, so things that they can do something about, surgery-related, which is actually really, really rare if you look at the number of patients with suboptimal weight loss in my series is less than 3% who actually got some anatomical issues related to their weight regain. And then genetic, looking at actually how many of those with poor weight loss have a suboptimal GLP-1, and again, that's about 50%. Eating behavior, sorry, just to highlight from the previous ones, this is a big table I know, but maladaptive eating behavior is probably one of those with the highest level of evidence in terms of it consistently shown to be related to weight regain. But what is driving that eating behavior? That's something I've been interested in through my research, and actually those with low GLP-1 response exhibit more maladaptive eating patterns. And this is again important because when we think about how we're going to treat that, just doing behavioural therapy alone is unlikely to be successful. It's much more likely to be successful if we are doing behavioural therapy plus GLP-1 treatment. So moving on to the treatment algorithm then. From my side, it's about comprehensive initial assessments, going through all the contributing factors and kind of dependent on the findings. And you've got to talk to the patient about being able to, there are things you can do something about, and there are things that you can't do anything about, such as genetics. But if there are changes to gut hormones, maybe you could add a GLP-1 pharmacotherapy if this is available in your practice, or revisional surgery or endoscopic treatment. So it's all tailored towards the contributing factors. The Barioptimized trial is a randomized controlled trial that looked at actually selecting those with low GLP-1 response and giving them additional liraglutide 3 mg once daily injection for 6 months. And it's clear you can see the benefit of an additional 9% total body weight loss when you add in liraglutide 3 mg, when the trials that have used in patients who are not selected for their GLP-1 response have much lower weight loss. So I think there's a role for targeted treatment and for selecting patients who are more likely to benefit from pharmacotherapy. So just to summarize here, I think adding in pharmacotherapy potentially, I think this is the future. Explore eating patterns, and really further into the future, we're considering revisional surgery based on gut hormone response. If patients who've already got a raw gastric bypass have adequate GLP-1 response, just adding liraglutide or GLP-1 really is going to be helpful. And then of course look at the roles of other gut hormones. So the final take-home message I'd like to just put across to you is that there's a lot of stigma to weight regain. So it's really important to be empathetic. I think even if you can't do anything, just to acknowledge that it's hard to have gone through it all and have not done well. But it's not all a loss, because people like to compare with people on TikTok or whatever. But in reality, even 10% of that weight loss is going to be helpful for their metabolic health. And if you are like our service, we are limited to availabilities of what other, we have no pharmacotherapy and limited revisional options, then it's a case of focusing on weight stability and small gains, not focusing on getting back to that weight nadir. I think that's a really, really important message. And actually, if that's what you're going to say to the patient, they will take that. It's just you've got to set that expectations right. And if you want to read more, this chapter in Mr. Agwal's book has all the details and all the references. I will highly recommend it.
Thank you very much. No question. We'll have a discussion at the end. And our next speaker